And you come from a medical background. Med-surg was levels 1 and 2 mainly. And assessing the patient was head to toe. And so this is a different type of assessment because it's not like you can touch or feel. There's 2 patients when you're taking care of a laboring patient. One is the mom and one is the baby. And the baby is inside. And so the only way we can actually monitor that baby is 2 ways. One is we can always ask mom if the baby is moving. A baby that is doing okay will be actively moving when woken up, because sometimes the baby's sleeping and the mom doesn't feel the baby move, but we can put some loud noise or have the mom drink something really cold or move the abdomen around to wake up the baby, and then the baby should begin to kick. It's just like if you were really sick in bed with the flu, you would just be lying there and you didn't want to move. When a baby is not doing well, it will not move. That is one way of assessing. But a better way, or more accurate way of assessing, is actually putting on monitors and assessing with using the fetal monitors available in the hospital settings. So we're going to look at assessing fetal heart tones. I think whenever I talk about assessment, it's always important to know what the norms are, because if you know what the norms are, at least if you don't know what's going on, you can also get somebody to help you identify what is not normal on the strip. There's really 2 types of methods that we use for monitoring. One is intermittent auscultation, and the other is electronic fetal monitoring. In the hospitals, we'll mainly use electronic fetal monitoring, and that actually feeds right into the computer system. Where we might see intermittent fetal auscultation is, if you look at A, we may see that used by midwives if a patient is in the tub, or we may see it used in the doctor's office. They just put this over the baby's heart and on the abdomen, and the digital display is right there. Versus if we use the electronic fetal monitoring, the monitoring system that we use feeds right into our computer system. So in the hospital, we mainly use electronic fetal monitoring. There's 2 types that we can use. One is external and the other is internal. Internal is a little bit more invasive, therefore we only use it if it's medically necessary. But it's an accurate assessment versus the external. I mean, if the patient's moving around or the monitors flip, it's not going to be as accurate, whereas the internal is more accurate, more invasive, and only used when medically indicated. External fetal monitoring consists of 2 things. One is the Togo transducer, or we just call it the Togo, and what it's going to do is it's going to pick up the contractions. So we put it on top of the fundus, and how it picks up contractions is the uterus is a muscle, and when the muscle contracts, it rises. So what it does is it picks up the rising of the muscle. So it picks it up millimeters per mercury. It is an external monitor, so you can see that it might have we might not be so totally accurate on it, because if the patient has a lot of adipose tissue between the muscle and where the Togo is, it would be more difficult to pick up contractions. In addition, if mom is moving around, the monitor not properly placed, we may have a harder time picking up contractions. That Togo really is to pick up the contractions about how far they part and how long they're lasting. It really can't indicate how strong they are, because you may think that the higher the heel on the monitor strip is the stronger the contraction, but remember, if there's adipose tissue in between, it may be a littler heel, and I'll show you on the next slide. But the strength of the contraction itself is about the same as it would show on a thin person. So basically, external fetal monitoring on the Togo will pick up the contractions, and it will tell us how far apart they are and how long they're lasting. The external ultrasound device will pick up baby's heartbeat. Now notice it's on the lower quadrant of the abdomen. On an earlier slide, I talked about how baby's positioned, and either the baby's on mom's right side or mom's left side, and that means the back. We pick up the baby's heartbeat right through the back, the upper back of the baby. That's the best place to be able to pick up the heartbeat. So therefore, if baby is lying on mom's left side, or the back is on the left side and the head's down, we're going to pick up fetal heart tones closer in the left lower quadrant. If baby was on mom's right side, head down, we're going to pick up fetal heart tones in the right lower quadrant. If baby was left footling breech, the the upper part of the back of the baby would be on the upper quadrant of the abdomen. So we can tell just by doing Leopold maneuvers or figuring out where the baby is, where to place the monitor. But just a helpful hint, 97% of babies are vertex or occiput or head presentation. Therefore, 97% of the time, we're going to find fetal heart tones in the lower quadrants, depending on baby's lying on the right side or the left side, or sometimes you'll get it a little bit towards the middle, depending on where the baby's positioned. The ultrasound transducer picks up the baby's heartbeat by ultrasound. Therefore, you'll see that flat surface on that the round part of the transducer. Because it's ultrasound, we need to use ultrasound gel prior to placement. And we usually put about the size of a nickel to a quarter size amount of gel. Most of the time, we do not warm the gel because patients tend to be a little bit warmer when they're pregnant, and the gel, actually, when it's cooler, is a little bit more refreshing. Internal monitoring is more accurate, but it's more invasive because it goes inside the cervix and into the uterus. We can pick up baby's heartbeat, and we call that internal fetal scalp electrode, or we can pick up the contractions, which is called an intrauterine pressure catheter, and that measures the strength of the uterine contractions as well as how far apart they are and how long they're lasting, and both are accurate. So therefore, if we're having trouble picking up fetal heart tones or picking up contractions, perhaps the patient is not progressing. We're not really sure how hard her contractions are. We want to start some medication called Pitocin to make the contractions stronger. We may need an accurate reading of those contractions, and we may place the intrauterine pressure catheter for accurate reading of contractions. Perhaps we're concerned about baby, and we're having a hard time picking up the baby's heartbeat through maybe mom's a little fluffy or has adipose tissue, and we may need an internal fetal monitoring. Sometimes if the baby's in distress or we're worried about the baby, we would put those on too. Remember, the internal fetal monitoring are a little bit more aggressive. And also, in able to place them inside the cervix, we need to make sure that the cervix is at least 2 centimeters or dilated, and also that the bag of waters is already broken. So those two factors must be present for us to be able to use internal fetal monitoring. Cervix must be dilated to 2 centimeters, and the bag of waters must be ruptured. Here you can see this is the internal pressure uterine catheter that's going to contractions. It just lies in the fluid next to the baby. Whereas the one that's going to pick up the heart tone is going to be attached to the baby's head. Here we can see the intrauterine pressure catheter line on the side, and this is attached to the baby's head. It's the correct placement, but it does not look like that. Let me show you a better picture. This is what would be placed on the baby's head to get an accurate fetal heart rate. Do you see that little spiral metal piece on the very tip of that on the left side of the scalp electrode? We actually will do a vag exam with that in between our fingers, and then we kind of like just screw that into the baby's head. I know it sounds really bad, but it just barely goes in. And when we take it off, sometimes it leaves a scar, a scab. But I will say this, is that scabs and little abrasions will heal, whereas brain damage does not. So if it's medically indicated, it can be a life-saving procedure with the baby. Again, the cervix must be dilated to 2 centimeters in order to use that scalp electrode, and the bag of water must be broken. I know in the hospitals where I worked, in a lot of hospitals, nurses are able to place that fetal scalp electrode for the baby's heartbeat, but in most facilities, the doctor is the only one who places the intrauterine pressure catheter. I will say that it's always policies and procedures, and it's important to know what the policies and procedures are of the hospital. So here we have the external monitor, which is outside the body, and the internal monitors, which are inside, a little more invasive, but more accurate. This slide is just to say that I talked earlier about the importance of patients being able to have the freedom of movement, how important that is to get the contractions and the labor going, to bring the baby down into the pelvis and to make sure it's in a good position, an anterior position where the head is looking down and the chin is to its chest, and how important that freedom of movement is. Therefore, it's also important to know that if you have a low-risk patient, they do not need to be attached to the monitor all the time. You can put the patient on the monitor for 30 minutes, get a good strip, baby looks good, mom looks good, and let her get up, go to the bathroom, get in the water, walk, get on the bouncy ball, whatever. If they are, though, a high-risk pregnancy, whether they've got preeclampsia, they're on magnesium sulfate, Pitocin, or whatever, sometimes we need continuous monitoring. So for the point of this slide is just to know that if you have a low-risk pregnancy, that in early labor and even active labor, it's really important to get them off the monitors and move them around. They're attached to a cord that plugs into the monitor, but we do have some hospitals have some wireless monitoring too, so they can go a certain distance, like a Bluetooth type of pickup, and they can go a certain distance from their room with those monitors that are wireless. Here's what a strip looks like. We used to have paper strips, but now that's you would see on the electronic monitor. Most monitors also have the capability of printing the paperwork in case something malfunctions in the electronic medical records, but most of the time it doesn't. If you look at this tracing here, the top is the fetal heart rate and the bottom is picking up the contractions. And that's what I talked about, like little hills. So it looks like, wow, those must hurt. And sometimes they go even higher. But again, if it's an external monitor, we're basically looking for when the contractions, how far apart they are and how long they're lasting. The top one is the fetal heart tones, and a normal fetal heart rate would be 110 to 160. So that line should be in between there. Sometimes you'll see a third line there, and that's the pulse oximeter placed on the mom, so we can see what mom's pulse is, because sometimes mom's pulse may be 110 and we don't want to confuse it with babies. So sometimes we'll put that pulse ox on so we can keep an eye on her pulse and also mom's oxygenation rate as well. If we did have paper, or if we looked really closely at the electronic fetal monitors, we'll have 1 minute intervals. And let's see if you could see them a little bit better. It's harder to see in these slides here, but it's more a little bit more visible. And most, I think that in future slides you'll see that. But if you can't really make out the 1 minute interval, all these fetal monitoring have little box is 10. So this would be 1 minute because there's little in there. So if this is a 1 minute interval right here, how do we time contractions? Well, we take it from the beginning of one to the beginning of the next, not from the peak to peak and not end to end, from the beginning of one to the beginning of the next. So that first contraction on the left is starting. And if you look at the 1 minute intervals, let's see how long it takes to get the beginning of the next contraction. That would be 1, 2, 3, 4, 5 minutes apart, because they're 5 minute intervals from the beginning of one to the beginning of the next. And you can see that those contractions last 60 seconds. I wish it was all that clearly stated, but sometimes you'll see on some future slides that it's hard to pick up contractions if it's not an internal monitor. So again, as I said before, on any assessment, it's so important to know the normal, because then if you know the normal, you'll be able to begin to identify the abnormal. Baseline fetal heart tones is 110 to 160s, and you need a baseline of at least 10 minutes to get that. So anything above 160 would be tachycardia. And again, you need a strip of at least 10 minutes to determine that is tachycardia. Bradycardia is a fetal heart rate of less than 110 beats per minute. So see how much you know already. You know what a normal fetal heart rate is, tachycardia and bradycardia. And as long as you know the norm, you'll know what tachycardia and bradycardia is. Let's look at this tracing here. Look on the top there. You'll see fetal heart tones. They're in the 130s. Okay, so if you look, that's kind of like the baseline right there. You'll notice, though, that it jumps around. It goes from 130 to 125 to 120 to 140. And that's what we call variability. Part of the norm on a fetal heart tones is we know that it needs to be between 110 and 160. But it also needs variability, meaning beat to beat. We do not want that line to be straight. That would be, if that line is straight, it's showing the baby has no oxygen reserves. So we like to see it range from beat to beat from anywhere between 5 and 25 beats. And here we have that because the average is about 130, but you can see it go down to 120 and you can see it go up to 140. So there's a range there and it's a squiggly line. This is what we call moderate variability. If it was a straight line, it would be absent, which would be good. If it was less than a 5-beat variability, which means very minimal, we would call it minimal. We do not like absent and we do not like minimal variability. We like moderate variability, like that's seen in this strip here, where there's a variation in the heartbeat between 5 and 25 beats. Now, if you look at the bottom, is she contracting or not? It's kind of hard to tell because it sure didn't look like that other one that we were looking at. This could be mom moving around, it could be baby kicking or whatever. So it's just to show you that the external fetal monitoring can be hard to differentiate, but she probably is cramping or contracting a little bit on this monitor strip. Again, sometimes you have to palpate the fundus to feel the contractions, and you can feel the uterus rise and you can feel it get hard, and you can actually time them that way and actually feel how hard they are and how mom is tolerating them as well if you did not have a monitor system. Sometimes you have to do that anyway just to make sure that the monitor is picking them up correctly. So here we have tachycardia is anything greater than 160. Bradycardia is less than 110. We do not like minimal to absent variability. We like moderate variability. And I will talk a little bit about a sinusoidal pattern, which is a bad, kind of a bad news pattern, but it's so rare. I've never seen it in my practice. So, but I'll mention it because sometimes in NCLEX and your adaptive quizzing, you may see that terminology there. So if we look at this strip here, we can see that the baseline is probably between about 170. We already said anything greater than 160 would be tachycardia. We can see that this patient is contracting, and some of those contractions are lasting more than a minute. Now, if my patient had been fine laboring and all of a sudden I saw some tachycardia, I'm going to tell you what my first thought would be. My first thought would be, and I would have to go into the room because this is an abnormal rating. But my first thought would be, I wonder if my mom is getting a temperature. Because when baby will get hot before actually mom gets her full temperature. But when baby gets hot, the baby will get tachycardia. So if I'm thinking the patient's been fine and now I have tachycardia, what would be the first thing I would do? I would probably want to get mom's temperature to see if she's getting a fever, which could mean maybe she's getting an infection. I would call the healthcare provider to let them know because he may want to order some Tylenol to bring down the fever. He may, and I probably will give her fluids because anytime a patient has a fever, they're burning off, and laboring patients are already in more of a dehydrated state because of their breathing, they're working hard, and they're probably not drinking as much as they normally do. So therefore, in our patients in labor and delivery, we're not so worried about fluid overload like you would be in some of your med-surg cases, like congestive heart failure and those. We're more concerned with dehydration. So a lot of times on our order sheets, we can give them an IV bolus of 500 milliliters of lactated ringers for any times of fetal distress, which this might be. So if she had a fever, the doctor may order some labs and also may order some antibiotics. There's other reasons for tachycardia. It could be illicit drugs or drugs that cause an increase in mom's heart rate that would also cause an increase in baby's heart rate as well. You can see in this one here, the baseline is 180s, moderate variability, which means the baby has some oxygen reserves. So if I acted immediately on this, I could probably figure out what's going on and maybe even treat it with some hydration, Tylenol, and some antibiotics if needed, and get labs. Because if you leave it untreated, it's not going to probably get better on its own. It's probably just going to get worse. If you look at the contractions on the bottom, you can see that she is contracting. So you see as on the left, that one contraction coming, and then the next one starts, and you can see that solid red line. So if you count the solid red lines after that, you can see when the next one starts. So you can see that contraction, the picture is starting. If you count the red lines, that would be 2.5 minutes to the next contraction. And those contractions are lasting about 60 seconds or minutes. So that's a really good tracing of contractions. You can tell how long they're lasting, how far apart they are, and that patient is contracting. Our concern would be tachycardia. We'd probably go in, get her temperature, probably give her a fluid bolus, call the healthcare provider, and go from. And if he orders any labs or antibiotics or Tylenol to take care of the tachycardia. So tachycardia is fetal heart rate greater than 160 for at least 10 minutes. It means that the baby has an early sign of not getting enough oxygen. It can result from a fever or maternal infection, but it also can be caused by hyperthyroidism and, again, some illicit drugs. So we've talked a little bit about a normal baseline of 110 to 160s. We like moderate variability. We know what tachycardia is, and the most common reason that we see in the hospital is either probably from drugs or infection. Here's a picture of bradycardia. Remember, bradycardia is a baseline rate of less than 110, and this one is probably in the hundreds and times in the 90s. Variability is good. You've got that nice variation. And if you look at the contractions, there is no contractions, and you could say this patient is not contracting. I have actually gotten a patient, somebody went to lunch and said, I just increased the Pitocin. She's not contracting. I went into the patient's room and she was hurting. And I looked at the monitor, and the monitor had flipped upside down, so it wasn't picking up anything. So I turned it right, and then she was contracting. So technology is good, but you always have to check your technology to see if it's matching what you're seeing in your patient. If I saw bradycardia, some big things that cause bradycardia is low blood pressure. And a lot of times with our epidural patients, which causes vasodilatation, we see low blood pressure, which causes bradycardia. Why would that do? Well, just think of when your blood pressure lowers, perfusion decreases. And perfusion of blood to the placenta decrease, which means less oxygenation to baby. Therefore, we're constantly taking blood pressures. There are some other things that can cause bradycardia. Sometimes some drugs that we give mom can cause bradycardia as well. Hypotension, or mom just lying flat on her back. If she's lying flat on her back, the weight of the uterus can actually occlude the main blood vessel, the vena cava, that is supplying blood and oxygen to the baby. So a simple thing as just a position change of getting her off her back can increase the blood flow and perfusion to the baby. As well as if you increased your IV, that would increase perfusion as well and increase the blood pressure. So those are some things we might think about when we see bradycardia. Significance really depends on the underlying cause. And if we look at the underlying cause, there's several reasons. But I'm going to say the ones that you're going to see the most is mom lying on her back and low blood pressure and medications and mom not getting enough oxygen. Yes, fetal cardiac arrhythmias, congenital heart block. For the sake of this course, we don't have time to cover all that. A cord prolapse can cause some bradycardia because remember we talked about it, how the head can come down on the cord, which occludes it, and baby will not get adequate oxygenation. So those are some of the main causes. So bradycardia, just like tachycardia, is fetal distress, meaning baby's in distress. And we have some actions that we automatically have orders for in our charts to take quick action on fetal distress. So for fetal distress, the first thing you would do is if you walked into a room is make sure the patient is off her back or change mom's position. You can also increase her IV rate to increase perfusion. And you can also give mom oxygen. Okay, so if you increase mom's oxygen, then you're going to increase baby's ability to get oxygen. So again, you can change her position. You can increase the IV rate to increase perfusion to the baby, and you can give mom oxygen. Now, in med-surg, you may give 2 liters via nasal prong or whatever. In labor and delivery, the standard is 8 to 10 liters via mask. So increase the IV rate, give her some oxygen, covers all your fetal distress. We actually call that intrauterine resuscitation. Let's look at this strip. See, in the darkened areas, that's where we're going to find the baseline. It's without the other variations in it. So the baseline is about 130s. You can see in that baseline, there's a variation of, probably, anywhere, but probably goes from 120 to 140, maybe even. So there's good variation. But you see on the undarkened areas how the heart rate goes up to like 180s, and it goes up for a whole minute. We call that, that is not variability because it's lasting longer than 15 seconds. Variability, the heart rate will go up to maybe 15 seconds, but then it'll go back down and it'll start moving around again. But do you see those accelerations? They continuously go up and they last for a while. We call that accelerations. Now, think about you when you go running. Your heart rate will increase to compensate for the activity you're doing or the stress you're putting on your body. If you look closely below those acceleration points, there's contractions or on the left, and the next acceleration, if you look below it on the contraction monitor, you'll see babies probably kicking and moving. Movement of the baby is stress on the baby, and if the heart rate goes up, yay, that's great. That means baby is doing fabulous because it's got fetal oxygen reserves, and it's got the ability to adapt and to adjust to the added stressors. Just like when you go running, your heart rate increases to adapt. So accelerations, okay, so this is like the most beautiful strip ever for a nurse because this means a happy baby. You've got fetal heart rate 130s with moderate variability and accelerations. Accelerations are on the cake, meaning baby is doing superb. Now, baby may not get those accelerations. It doesn't mean the strip is bad, but to have those accelerations mean baby, it's reassuring, it's positive, it's a good thing. Happy baby, happy mom, happy nurse. Fetal heart tones 130s, moderate variability with accelerations and accelerations with contraction and fetal movement here. Variability is the single most important indicator of fetal well-being. It's the paramount indicator of a well-oxygenated fetus. Okay, it means baby has oxygen reserves, and it reflects the neurological modulation of the sympathetic and parasympathetic nervous system. Basically, baby is a happy baby. We talked a little bit about variability. We know it's an important indicator of how well baby is doing. We do not like absent. We do not like minimal. We love moderate. And marked is when it's going, and I'll show you a picture, and usually it doesn't have really it's really not significant. Usually it just means baby is like really super active at the time. So here, this would be absent or minimal, and really it doesn't matter because it's bad, whether, absent or minimal, they're both bad. It's variation less than 5, it's a straight line. You need to do something about it or it's just going to get worse. The fetal heart tones are about 155, which is normal, but it's absent variability and you need to do something. This is fetal distress. So for fetal distress, I would position my mom on her left side or right side to increase perfusion to the baby. I would increase an IV rate to increase perfusion of blood to the fetus. And I would give mom O2, 8 to 10 liters via mask to see if it improves. Here's again, absent variability. It's just a straight line. It needs an attention because remember, it's the single most paramount indicator of baby's oxygen reserves. Minimal is not good, okay? And it could be all kinds. Basically, it's resulting from baby not getting enough oxygen. It could be due to medication, some kind of previous neurological injury, congenital anomalies, but whatever, it is distress on the baby and it needs to be addressed. Here's that marked variability where the significance is really unclear. Baby could just be doing somersaults or just really active, and it's just got great variability. And usually after a while, it'll go away. So just a refresher, we've learned a lot. We've learned normal fetal heart rate is 110 to 160s. We like moderate variability. We do not like absent. or minimal, and marked is kind of insignificant. So we like 110 to 160s, and we like moderate variability, and accelerations are icing on the cake. We're also going to talk a little bit about some decelerations that we may see as well in the fetal tracings. We already talked about accelerations, how they're transient increases above the fetal heart rate. Usually it's connected with fetal movement, contractions. Accelerations are positive, they're reassuring. It means it's a happy baby, you'll be a happy nurse. Here's another strip showing accelerations. You can see the baseline fetal heart rate is 150s, moderate variability with accelerations with contractions up to, wow, 170s, 180s. Happy baby, happy mom, happy nurse. You can see that patient is contracting with accelerations. So let's talk a little bit about some periodic changes that we call decelerations. We'll talk a little bit about early, late, variable, and prolonged decelerations. Early decelerations. Look at the contractions. Early decelerations mimic or mirror the contractions. When the contraction begins to go up, the fetal heart rate goes down. At the peak of the contraction, you'll have the peak of the deceleration. Once the contraction goes down, the fetal heart tone goes back to normal. Now here we've got a normal fetal heart rate of 130s. Notice those contractions, they almost look like little peaks. It's probably because the patient is pushing. She's pushing, and that's where you see the peak, and then she takes a breath, and then she pushes again, and you'll get another peak. Early decelerations are not a bad thing most of the time. They're an expected finding of somebody who's in transition or pushing, because what it is, it's caused by head compression. As the baby is going through the birth canal and it's getting ready to deliver, that head gets compressed, and it causes early decelerations, particularly when the patient is contracting or pushing. Sometimes if their baby has a large fetus or a large fetal head and it can't fit through the, it's having a hard time fitting into the pelvis, you may see early decelerations early on, which may indicate the baby's not going to fit. But for the sake of this class, and the majority of times, early decelerations are a normal occurrence when the baby's head is descending. So it's caused by head compression. So here you can see the contraction as it begins, the fetal heart rate goes down, and then at the peak is where it's the peak of the contraction and the lowest point of the early deceleration. Once the contraction goes down, the heart rate goes back up. It's caused by head compression. You can see on those contractions there, that first contraction, that to the next contraction is a little over 2 minutes. So that patient's got a good contraction pattern about every 2 minutes. And those contractions are lasting a good 60 plus seconds. So early decelerations are caused by fetal head compression. It's a normal finding. Again, here you can see, same thing. It's a mirror image of the contractions. If you turn the strip upside down, it would be a mirror image. So early decelerations are an expected finding for head compression as the baby comes down the birth canal. Now, variable decelerations aren't necessarily normal thing. It's something we would watch for. A variable deceleration is abrupt down and abrupt up. It can be associated with contraction or not even with a contraction at all. And it's caused by cord compression. So let's say the way the baby's cord is, maybe you've got mom positioned on her left side and baby is lying on the left cord. Then you'll see some variable decelerations. Well, then just turn her on her right side, get the baby off the cord, and that should return to a normal strip. There are some times though when there's many reasons why amniotic fluid is important, but one of them is it cushions the cord. There are some cases where there's some patients have a decreased amount of amniotic fluid due to some high-risk conditions, and that can cause variables as well. And we'll talk about how to take care of those in a slide or two. But most of the time, it's baby lying on its cord. Just position the baby to get baby off the cord. If you're concerned and you want, this could be baby in distress, you could still give her some O2 and you could still increase the IV rate. But really your big thing would be to change the position and get baby off the cord. I did have a baby who had variable decelerations periodically throughout her whole labor. No matter what position, they were still there. The baby came out holding the cord and occasionally squeezed it to cause a deceleration. Again, it's cord compression. Just change the position of the mom. Another deceleration is a late deceleration, and it means the baby's not getting enough oxygen from the placenta. So we call it, the cause is uteroplacental insufficiency. It means baby is just not getting enough oxygen from the placenta. So there's insufficient placenta perfusion during the contractions. It can lead to some bad things. So if we look here, how we can tell a late deceleration is at the peak of the contraction is when the deceleration begins. Remember at the early, it started when the contraction began. Here it begins at the peak of the contraction or after, and it's slow to recover. So by the time it gets back up to the normal heart rate, maybe it's in between contractions. So it's a late onset, meaning at the peak or after, and it's slow to recover. Okay, so that'd be a late, and it's caused by uteroplacental insufficiency, which basically is fetal distress. So as a nurse, first thing you think of is, okay, fetal distress, what am I going to do about it? Turn the patient to increase perfusion, give her more IV fluids to increase perfusion, and give mom some oxygen, 8 to 10 liters via mask. Here you can see at the peak of the contraction, right after it, the heart rate goes down and it takes a while to recover. That is a late deceleration caused by uteroplacental insufficiency. A prolonged deceleration is just what it says, a long time. So prolonged deceleration is a contraction lasting more than 2 minutes, but less than 10, because if it lasted 10 minutes, that would be bradycardia. It's a disruption in the fetal oxygen supply. And remember, every minute that if it keeps going down, prolonged, if it kept going down, that would mean the baby is not getting enough oxygen, and it could cause some brain damage. So we do not like prolonged decelerations, particularly after 2 minutes. If it was prolonged for about 5 minutes, we need to get that baby delivered, because 5 minutes without oxygen will just continue to lead to problems. If you look at this slide here, maybe you were in with the patient and you could see on the very left, probably the heart rate was good. It was in the 150s. You had some moderate variability. Then all of a sudden it started to go down, and you could see those solid lines where it shows the minute intervals. Looking at 1 minute, it's already down to 1/10. If you're in the room, you can hear it. If you have a little volume on, you can hear it goes da-da, da-da, and then it starts going da-da, 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 da-da. The minute seems like forever. Probably at that 1 minute interval, I probably would have repositioned her, increased her IV rate, and get in the oxygen. But look at, after 2 minutes, it continues to go down, and now it's in maybe down to 100, and now it's going down to the 90s after 2 minutes. Believe me, by this time, you've repositioned, you've given her oxygen, you've given her IV fluids, the charge nurse has probably been notified in there, and then it continues to go down, and now you're on 1, 2, 3 minutes. You probably notified the OR to open up, or you checked her cervix to see maybe if you can get her delivered vaginally. 5 minute mark, and then it finally comes back up. That's the longest 5 minutes of your life. Now, a 5 minute deceleration like that for prolonged, the doctor would be notified and would come in. There, because there's good variability and it went back up, he'd probably watch. But if she continued to do that, she would be, she would probably be almost in line for the OR, because we don't want to take any chances, and that baby is not getting enough oxygen for 5 minutes. So we get a little concerned with that. So we have to think about delivery when we see prolonged decelerations. Maybe she had that prolonged deceleration. It was a fast descent to the baby and she was complete and ready to push. That would be great. Maybe she was 2 centimeters and started to do it again. That would not be so great, because delivery probably would mean an impending. So what do we do for fetal distress? What do we do for abnormal strips? change mom's position, increase the IV rate, give her oxygen 8 to 10 liters via mask, notify the healthcare provider, and start planning for a delivery. When we talk about fetal heart rate, they have a 3-system tier in the hospital. We have category 1, 2, and 3. 1 is a happy baby. We already know what a happy baby. Fetal heart tones 110 to 160s, moderate variability, no decelerations. Maybe earlies would be okay. Category 2 is those like, red light, yellow light. They'd be in the yellow zone. Like, you better do something about it or else. Category 3 is just bad, bad, bad. Now, I was looking for an easy way to remember things. Category 1 is just a happy baby. You've got a normal fetal heart rate, moderate variability. Early decelerations are either there or not. Accelerations are either there or not because sometimes the baby's sleeping and there are no late or variable decelerations present. We already know that. Category 2 seems a little lengthy for me, but if I looked at category 3, that defines what's really bad. Absent baseline variability with recurrent lates and recurrent variables in bradycardia, and then that weird sinusoidal pattern. Well, that's easy. So everything else is the yellow light and in between. This is a picture of the sinusoidal pattern, which is a category 3, and sometimes you'll see it on your adaptive quizzing. But basically, it's caused by severe fetal anemia. Sometimes it used to be the Rh factor, which we have ROGAM now. It's a very uncommon pattern, so you'll hardly ever see it. I wouldn't test you on it, but you may see it on a quiz or an adaptive quizzing. But that's a sinusoidal pattern. It's just undulating. You can see it's up, down, up, down, up, down, up, down, up, down. There's pseudo sinusoidal patterns too, sometimes when you medicate a patient. But for purpose, because it's such an uncommon pattern, I think it's more than what you need to know. But again, you put it in there because your book talks about it and adaptive quizzing may talk about it as well. How to remember all this stuff? Well, you know that a normal fetal heart rate is 110 to 160s. You know you like moderate variability. You know that early decelerations are head compressions, which okay. But how do you remember this stuff? You just write down veal chop. On the left is veal and on the right is chop. If you have V for variable, what causes variable? Let's look across. Cord compression. Okay. E is for early. What causes early? Go to H. Oh yeah, head compressions causes earlies. Accelerations, you go across, it goes to the O on chop. Accelerations are okay, they're actually good. And L is for late, you go across, it goes to placental insufficiency. So there you go. This is a good way to remember what causes what. Variables are caused by cords, earlies are caused by head compressions, accelerations are good, and lates are caused by placental insufficiency. Again, nursing interventions for non-reassuring or abnormal or fetal distress, fetal heart tone patterns, change mom's position, increase the IV rate, and that could mean an IV bolus of about 500 lactated ringers. Administer O2 at 8 to 10 liters via nasal prong. Notify the healthcare provider. And in addition, you might see an amnioinfusion and stimulation. Now, I'll show you what an amnioinfusion is, but stimulation just means, what if baby's just sleeping? Sometimes if you do a vaginal exam and you scratch the baby's head, if the bag of waters is broken, or even just kind of rub it, baby will wake up and respond with movement and the heart rate will increase. If you do that and it doesn't, then the baby is not responsive, then you've got more of a problem. So interventions, I always try to think of easy ways for you to remember. This is probably the only time that you'll hear your professor say, give your patient poison for fetal distress. Poison stands for change the position of your patient. If she's on oxytocin, which causes stress because it causes contractions and you want to decrease the stress, you turn it off. If the baby's in trouble, turn off the Pitocin to decrease the stress of contractions. Give an IV bolus. Check her vaginal exam. Check her cervix to see if she's near delivery or ready to push. Give her some oxygen, 8 to 10 liters via nasal prong, and notify the healthcare provider. It talked about an amnifusion. Remember I talked about some babies lack the proper amount of amniotic fluid? For serious, some high-risk reasons, sometimes they just don't have enough amniotic fluid. And one of the functions of amniotic fluid is to cushion the cord. So remember the internal uterine pressure monitors that we put on? We talked about internal monitoring, the one that we put in to measure contractions. It has a little port where we can actually add normal saline and put normal saline into the uterus to cushion the cord, which would take care of variables caused by low amniotic fluid. Again, how to remember? Remember your veal chop. Think of your veal chop as you answer question 1. The nurse providing care for the laboring patient. Variable fetal heart rate decelerations are caused by, we said variables are caused by cord compression. If you had your veal chop, you would remember that too. A nurse caring for a woman in labor understands that maternal hypotension can result in early decelerations. Well, that's caused by head compression. Fetal arrhythmias, well, we didn't even talk about that. Uteroplacental insufficiency. Well, remember, if we have low blood pressure, we're not going to have perfusion to the placenta, so uterine placenta insufficiency is the answer. Spontaneous rupture of membranes? No. Question number 3, a nurse is caring for a laboring patient understands that early decelerations are caused by, well, if you did veal chop, we know earlies are caused by head compression. Oh my, where does it say head compression? It doesn't. It says altered fetal cerebral blood flow. Well, cerebral, that's head, flow to the head. Maybe that's it. Well, let's see what the others say. Umbilical cord compression? No, that causes variables. Uteroplacental insufficiency? No, that causes late or prolonged. Spontaneous rupture of membranes? No, so it's gotta be